definition of brady, what we mean by bradycardia, specific disease of sinus node and AV node. Bundle branch block is actually not the cause of brady, but it's important to recognize in ECG and part of the conduction system problems. So we'll go over them. And later we'll talk about how to approach patients with bradycardia. So the first part of the conduction system, of course, the sinus node. And you know the anatomy is located in the high right atrium at the junction with SPC. Normal rate is 60 to 100 beats per minute under resting stage without physical activity. Blood supply, right coronary artery about 55% of the time. 45 comes from left circumference. Sympathetics increases the rate from the sinus node. Parasympathetic decreases the rate from the sinus node. So sometimes during sleep, we see bradycardia, rate 40, sometimes we need people up to 35. We don't worry about it because this is physiologic. High vagal tone during sleep, increased parasympathetic, it can suppress the heart rate. The second part of the conduction system, AV node, it is in the lower atrium, close to the tricuspid valve, and the blood supply here is right coronary artery 90% of the time. So inferior myocardial infarction more likely to produce AV block than anterior or other because of anatomy. Supply is the same area. The sympathetics increases the conduction and enhances conduction. So what will happen to the PR interval? The exercise gets shorter. During sleep, the PR interval is longer, but usually still within the normal range, which is 3 to 5 small squares, 120 to 200 milliseconds. And the rate from here is about 40 to 60. We call that junctional rhythm. If more than 60 but less than 100, accelerated junctional rhythm. Above 100 is junctional tachycardia. The last part of the conduction system, bundle of Hess. Right and left bundles. We know right bundle is only one bundle. Left is anterior and posterior vesicles, important when we discuss the conduction problem. Blood supply mostly from left anterior descending artery. The proximal part may have dual supply from right and left system, mostly from left anterior descending artery. What is bradycardia? Just slow heart rate. And by definition, we say heart rate less than 60 is bradycardia. Most of the time, no symptoms except if it is less than 50. So you see it also some textbook, they say, okay, bradycardia heart rate less than 50 beats per minute because they are looking to symptoms. Rarely there are symptoms if the heart rate is above 50 beats per minute, but by convention, 60 is the most acceptable definition. Now, if you want to see what conduction system problems in general, it could be in the sinus node, and we will learn today about sinus brady, exit block, arrest, tachybrady syndrome, which is the sixth sinus, typical sixth sinus, but others also part of the sixth sinus, chronotropic incompetence, we call it, first, second, and third degree AV block, and the bundle branch block, right and left bundle. For causes of the conduction system problems, we can classify them into two conditions. One is functional, second is pathological. What functional means? Could be either physiological or sometimes we call it extrinsic. So the conduction system is normal, but there are other factors that affect the conduction system. Typical example, vagal tone, vasovagal syncope, for example. What happened? Vagal tone increase significantly. They have brady, they may have a pause. It's just for seconds, and then they recover. There's no problems in the sinus node itself. It is just the innervation of the sinus node is affected. Once we eliminate that, they are back to normal. Other typical example is pharmacological causes like medications. We know beta blocker, calcium channel blocker, digoxin, most of antiarrhythmic medications can stop the heart rate. And sometimes if the patient is not necessary to have, for example, beta blocker, we stop it. Heart rate goes up to normal. This is okay, just secondary to the medication. So it's not pathological, the conduction system is not disease. Electrolyte problems, severe hyperkalemia, hypokalemia, hypercalcemia, hypocalcemia can be associated with bradycardia. And once you correct it, they are back to normal. It means that the conduction system is normal. This is some extrinsic factor affecting the conduction system. Okay. Pathological causes is intrinsic system. So that one is extrinsic. This is intrinsic in the conduction system itself. And like any disease, it could be congenital. Do you have example of congenital that cause bradycardia? Congenital disease?
Congenital is a malformation.
Congenital? Complete heart block. There's congenital complete heart block. So some people, they're born actually with no conduction in the AV node. So that's, well, it's not uncommon. Congenital sixth sinus syndrome. You see some families actually, they have sixth sinus from young age, from age of 6, 7. They have sixth sinus syndrome from a younger age. congenital. There is genetic disease behind it. Degenerative change. The commonest cause elderly people, they need a pacemaker. It's degenerative change with ages in the sinus node, so they have sick sinus syndrome because of degenerative changes in the sinus node. Ischemia or infarction, remember, blood supply to the heart is the blood supply to the conduction system, including AV node and sinus node. It's more common, of course, with right-sided infarct than left-sided infarct. Any infiltrative disease of the myocardium, like amyloidosis or sarcoidosis, because the conduction system is embedded within the myocardium. So any disease that infiltrates myocardium may infiltrate the conduction system at the same time. So it can cause conduction problems. Inflammatory conditions like vasculitis or myocarditis sometimes can involve myocardium, can involve the conduction system, and can cause the bradycardia. Post-operative or trauma, we call it iatrogenic. So somebody has a valve replacement and it's close to the AV node. They can get damage to the AV node and they need a pacemaker. If it is only transient, it could happen because of edema around the tissue and it resolves. So the transient AV block, for example, this is not an indication for pacemaker. But after 5-6 days of surgery, complete heart block is there, this is pathologic now, and they may need a pacemaker. And of course, other systematic diseases. The most common is hypothyroidism. Always when patient bradycardia unexplained, we have to check thyroid function. So it could be congenital, degenerative, the eyes, ischemia, infection, infiltrative diseases, inflammatory diseases, iatrogenic, or hypothyroidism, systematic diseases. Okay. Now let's talk about sinus node disorders or dysfunction. So this is a problem with impulse formation in the sinus node or impulse conduction from sinus node to the atrium. This is the two pathological diseases that could happen. And we will discuss today diseases like sinus bradycardia, exit block, arrest, the two we call it sinus pause, and if you don't differentiate between the two, it's not important. You know? Tachybrady and chronotropic incompetence. So what do you see in this lead to rhythmus? Business only bradycardia. Other than that, the patient is sinus, there is no significant abnormalities except the bradycardia. So sinus bradycardia is actually common, and sometimes in athletes is normal. So during rest stage, they have vagal tone. Brady during sleep is normal. Some elderly patients actually they have rate always in the 50s, but when they exercise, actually the rate goes up. So there is no problem. Don't worry about it. So this could be normal variant, and most of the time there is no symptoms related to it. If they have bradycardia with dizziness, fatigue, palpitations, or syncope, and there is no other explanation, then they may need a pacemaker. Very rarely you put a pacemaker just for sinus bradycardia. So this is the first condition, sinus bradycardia. Before I move to the exit block and arrest, just let me remind you, when the sinus nodes start to fire, it is small tissue. We cannot detect firing of the sinus node by electrode outside the body. So we don't see anything when the sinus node just fires or activated. When it conducts to the right and left atrium, now we have depolarization of larger tissue, the left and right atrium, left atrium and right atrium. Then we have a P wave. So when we see a P wave, and the P wave is rounded in lead 2, positive in inferior lead in lead 1, we say, okay, this is most likely coming from the sinus node. So it's actually indirect evidence that the sinus node is working. So because when it fires, then activate the atrium, we see a P wave. So if the sinus node stops firing, what do you call that? Arrest. So again, there will be a pause. Then when it comes back again to work, then we'll have the P wave and the KRS complex. If the sinus node is firing normally, and now 1 conduct, 2 conduct to the atrium, I have a P wave, P wave. 3rd did not conduct, there will be no P wave. Then the 4th conduct, there will be a P wave. So it is more of pattern that it is regular, and then we don't have a P wave in between. How to differentiate? You can look to this ECG or rhythm strip. What do you see in this rhythm strip?
Irregular.
It is irregular because of that area. Yeah. Okay, and there is no sinus activity, so we can call it a pause, sinus pause. Then I ask myself, is it arrest or exit block? The best is to map the P waves. So this P wave, this is here. The next one I expect it to come here. Yes, it is not there. But the one after comes on time. So what it tells me, sinus node is firing the same rate. So this is more exit block. Okay. This is the exit block because it comes on the time. The beat after the pause is coming on time. And the other way, you say, okay, this to this is actually like double this to this. Double the P wave, the normal. So it is double or triple. It means the sinus node firing the same rate, but sometimes not conducting to the atrium, so I don't see P wave because of no conduction. And we call it exit block. Arrest actually is usually number 1 longer, Number two, this pulse from here to there is no relationship to this P wave to this P wave. If I try to map them, one here, one is not in that area, usually slightly after, then another one. The other clue is that the rate usually after is slower than the rate before, because sinus node is disease with pulse. It starts to recover, it takes longer time, so there will be slower rate after than before. For me, that's not important differentiate, it's exit block or arrest. You just mentioned there is sinus pulse, and this is indicating sinus node disease. This is the important thing. And of course, is this less serious or more serious than bradycardia?
More serious.
More serious than bradycardia.
No.
It's not necessarily. So if the patient like this, and he has junctional area which is active, and they have escape, we will have what we call escape junctional beat, so the junctional beat will come here. But in cases like if there is the secondary pacemaker is not working, delayed, we'll have the pulse. And even if you see junctional escape rhythm, it does indicate the sinus node is not working. Why should junctional now start to work, where the primary pacemaker of the heart is the sinus node? And that's actually different between premature junctional and escape junctional. Premature junctional, premature beat comes before the next sinus, so this is not sinus disease, but just activity from the junctional area. Junctional escape is actually after a long pause, which is longer than the RR. What it means, the sinus node did not work as it's supposed to be, and that beat is coming, so we call it escape rhythm. So in this case, because there is no junctional, we have the pulse. The third one is called tachybrady syndrome. And from its components, brady is expected because if sinus node is not working normally, at baseline you have sinus bradycardia. But why tachycardia, you think?
Compensation of sympathetic nervous system.
Ectopic beats.
Okay. And that ectopic beat predisposes to? All other, actually it is not sinus tachycardia, because some people they think sinus bradycardia, sinus tachycardia. No. Sinus brady is expected, but actually tachycardia is abnormal tachycardia.
From junctional.
Because if the sinus node is not working normal, there are more premature beats in the atrium. That can predispose them to go into atrial fibrillation, atrial flutter, or atrial tachycardia. So that is actually pathological tachycardia, it's not like sinus tachycardia in this condition. So they go into like atrial flutter, atrial fibrillation, and ventriculitis fast. What will happen if the tachycardia is stopped? Patient in AFib, now AFib is stopped. What will happen?
Bradycardia.
They should go back to the sinus, right? This is the normal, because sinus node will be suppressed and then back to normal. If patient with 6 sinus syndrome, what will happen? It takes longer time to come back, so they will have a pause after the tachycardia, and then they are back to the baseline, which is the sinus bradycardia. So it's actually it's a triad of things. It's not only one thing. It's not tachybrady, but there is also pause in between. I'll show you an example, but make life easy. So this one actually is diagnosed mostly by Holter. It's not by ECG. Because I may do ECG sinus bradycardia, or I do ECG as in fibrillation, for example. But the only way to know this triad is to do continuous monitoring. And this is like a Holter. It's hooked up for the patient for 24, sometimes 48, sometimes 72 hours. And in this case, this is actually a real patient who is elderly with diabetes, hypertension, and has syncope twice. He lost consciousness transiently for some time. What do you see in this one?
Normal.
No,
it's
Normal
brady.
sinus. And this is 2 leads, by the way. The Kelch complex here is very, very small, but you can see it in the other lead. And this is modified lead. I show you an example at the end. It is not the same as 12-lead ECG. We'll put it in specific places, but it is called modified leads. So we have 2 leads at least to monitor. What is happening here now?
Tachy.
A
Irregular.
is tachy and
Irregular.
irregularly irregular. Excellent. And this, if you look to this one, you may think of fibrillation. But if you look to this one, actually more flutter, because more organized activity. And if you see more organized activity in one lead, most likely to be flutter. But it doesn't make a difference. Flutter or fibrillation, there is irregular rhythm and it is fast rhythm.
Doctor, where is the bradycardia?
We'll come now. We'll see an example. This tachycardia is stopped. So normal people, if they are in atrial fibrillation, young people may have atrial fibrillation for different reasons, or middle age. Once the fibrillation is stopped, the sinus node should come back again to work if it is normal. Usually within 1.5 seconds. So 1, 2, 3, 4, 5. This is 1 second. 1, 2 is so I expect the sinus to come here. In normal people. And actually, most of the normal people may immediately come actually too, but within 1.5 seconds is expected. If it is more than 1.5 seconds, this is abnormal. And in this patient, it was like 3-second pause, and this is the bradycardia. So you see now, there is tachy, there is a long pause, and there is brady. Once we see something like this, we are dealing with tachybrady syndrome, and this is mostly we refer to it as 6 sinus syndrome. But anyway, 6 sinus syndrome, any of the diseases we are mentioning now is part of the 6 sinus syndrome.
They're the same patient or different?
The same patient. We're just monitoring him over time. Sometimes he's normal sinus, sometimes his sinus brady, sometimes he's sagging, and sometimes he has a pause. And that's why I mentioned we have to do it long-term monitoring. It cannot be just
Yeah,
with
doctor.
ECG.
Doesn't have to start with bradycardia.
Baseline is brady. Most of the time, most of them, they have baseline bradycardia. But even if they have normal rhythm, like this patient, for example, if I do ECG, is 70 beats per minute, but has syncope. I do Holter, and it showed me this is 6 sinus syndrome.
Doctor, six sinus syndrome is more general than tachybrady, right?
Yeah, it's more. But if you divide it most of the time, and they put it between brackets, because most of the cases they come to emergency or see them in the clinic, they have this form of tachybrady. And that's why most of the people fixate with sinus syndrome when they have tachybrady. And it's the commonest. But anyway, this tachybrady or sinus syndrome, any of the disorders I showed you earlier, but it is mild, moderate to severe. This is one of the severe forms. So if you just refer to it, and that's why I prefer to say tachybrady in this one, not the only 6 sinus.
After getting the bradycardia, can it go back to fibrillation or bactically?
Actually, this patient is this another time. He was in fibrillation at another time. He has a long pause. So you may have a different time. But once we see tachycardia, we see bradycardia and pauses in between the triad. We are dealing with tachybrady syndrome, which is one of the manifestations of 6 sinus syndrome. No, I mentioned earlier it's pathological, like this atrial fibrillation, atrial flutter, or atrial tap.
How do I know that I have to quote modified lead when he has bradycardia?
This is just say order holder. They will do it for you. They will give you the rhythm strips. You don't need to worry about which lead or whatever. This rhythm strips given to you, and clearly a patient's bradycardic at one time, and has atrial fibrillation, atrial flutter at another time, and has a long pause at another time.
He means that we usually do ECG.
Normal ECG.
Normally, we do only ECG, but
Yeah.
when
This is
do we,
like rhythm strips. So that's what we. And I'll show you the example of the halter at the end, how we hook it up.
sure.
ميدات مختلفات من ضروري